afternoon, everyone. So, my name is John, and for this afternoon, we're going to talk about basic A to I assessment in critical care or in the critical care setting. Okay, so let's start. So, we've got this keyword assessment. Okay, so let's define what assessment is first. Okay, so assessment is a systematic collection of information relevant to the care of the patients, their problems, and their needs. Okay, so take a look at the word systematic. Okay, I'll just get the laser. Where is it? This one. Yeah. So systematic. Okay, when we say systematic, what does it mean? Systematic means organized, logical. Okay, so organized collection of data or information regarding patient care. Okay, regarding the patient. So its focus is the patient. Okay, in order for us to assist with their health problems or health needs. Okay, so we need to collect the necessary information. Okay, in order to address their health needs or health problems. Okay, so we've mentioned A to I, so what do they stand for? So here we are. Okay, so we start with letter A. Letter A in A to I stands for airway. Okay, airway. So in airway, we talk about if it's a patient's own, okay, if it's the patient's own. So how do we know if it's patient's own? Okay, for example, a patient's talking in full sentences, so that means the patient's airway is patent, okay? There's no artificial airway, okay? And then in airway, we've got some airway problems as well. So we encounter this in the healthcare setting. So we have number one, we have stridor. Okay, so what is stridor? So it's a high-pitched sound that may indicate airway obstruction. For example, upper airway obstruction in your trachea or pharynx or larynx due to, for example, foreign bodies. Okay. Number two, you have snoring. So snoring is very common when we sleep, okay? And it can be an airway issue as well. So this happens when airflow through the nose and the mouth is partially blocked during sleep, okay? There are some factors that can lead to snoring or can cause snoring. So one is position when you sleep or when we sleep, okay? When we sleep on our back, okay? Another is being overweight, okay? Because it adds some tissue, okay? Tissue or tissue mass inside there, and then alcohol intake as well, okay? Because it helps relax your airway as well. So again, snoring occurs when the airflow or the airflow it occurs when the air flows past the relaxed tissues in our throat. Okay? For example, tongue muscles relax, and then it can cause air vibrations, causing this familiar airway sound, okay, that we hear during sleep. Okay, and then the third one is gargling, okay? Gurgling sounds. So gurgling sounds may be related to what? Maybe secretions that a person cannot expectorate or cannot expel or cough up. Okay, that's why there's gurgling. Sometimes it's if it's too difficult to cough up, so a person, for example, in the healthcare setting needs assistance. For example, the nurse or the physiotherapist or the doctor may need to suction those secretions from the patient's mouth in order to clear them and make the airway open again, okay, or more patent. Okay. Airway adjuncts. So what are airway adjuncts? These are devices used in the healthcare setting or medical setting, no? In order to maintain an open airway or to relieve obstruction, okay? So we've got two common airway adjuncts in the healthcare setting or critical care. So you have the oropharyngeal airway or the OPA, and then your nasopharyngeal airway or your NPA. Okay, so what's the difference between the two? So here are some photos. Okay, so on your left, that's your oropharyngeal airway, available in these sizes. And then on your right are your nasopharyngeal airway or your NPAs, available in those sizes as well. In some references, there are like further sizes for the NPA. So where do we put the oropharyngeal? So as As we said, no, as the name implies, oro. Okay, oro pertains to oral, oral pertains to mouth. So we put this airway adjunct in the mouth, okay, patient's mouth or person's mouth. Whereas the nasopharyngeal, okay, naso, so it pertains to the nose. So we insert this type of airway adjunct into the patient's nose or through the patient's nose. Okay? What else? Another main difference between the two is the OPA or oropharyngeal airway is often inserted to whom? Patients or people who are unconscious. Okay? Otherwise, if the patient is conscious, like you and me, we won't be able to tolerate this type of airway. Okay? We will be distressed when someone puts one into our mouths. Okay? And then the nasopharyngeal, okay, this is often inserted in the nose or through the nose of people who are semi-conscious or sometimes conscious people. But they're not like conscious or alert enough to support their airway. So they need this adjunct to help maintain their airway. Okay? So that's that. And also we take note of the size when we do our assessment. What airway adjunct is there? What size of the airway adjunct is there? Okay? Okay, next. So still under airway, let's talk about intubated patients. So intubated patients, we talk about endotracheal tube, okay? But before that, what's an endotracheal tube? Endotracheal tube, or commonly known as ETT, is inserted through a patient's throat. Okay? Endotracheal. Endo meaning inside. Okay? Inside. Tracheal pertains to the trachea. Okay? Or the windpipe. Okay? So, why does a person need this one, this endotracheal tube? Okay? To establish an airway for mechanical ventilation. Again, the patient is not conscious enough, not fully alert to support his or her own airway. So something must take over. Okay, we need to help this patient breathe. We need to get this oxygen into his lungs for the oxygen to reach the vital organs like the heart, like the brain. Okay, so in order for that to happen, we need to somehow take over the patient's breathing or assist the patient's breathing by inserting this endotracheal tube, okay, which is attached to the mechanical ventilator or the breathing machine. Okay, but when do we do this? That's the other question. So when do we intubate patients? By the way, in most settings, it's the anesthetist or the doctors who intubate the patients. Okay, most often the anesthetist, okay, or the intensivist. Okay, so two examples or two scenarios where the doctors put the endotracheal tube. So number one, if a patient has low GCS or Glasgow Coma Scale or level of consciousness, patient's too drowsy, okay? The patient is too drowsy to the extent that that person cannot support his breathing, his oxygenation, okay? So that indicates that the endotracheal tube may go in, okay, to facilitate the mechanical ventilation. And then another scenario where intubation is needed is in respiratory failure. So some conditions, clinical conditions, some people, their respiratory system just shut down. That's why it's called respiratory failure. The respiratory system fails to function. Okay? And what's the function of the respiratory system? Let's do what? Deliver oxygen to the body. Okay? Or, in other words, oxygenation. Okay? Delivery of the oxygen is through the blood, but the respiratory system is the main system for oxygenation. Okay? Through the lungs. Okay? So, because the lungs is not working well, okay, then we need to assist the lungs through intubation or mechanical ventilation. Okay? So in terms of intubated patients and endotracheal tube, so when you see an intubated patient, for example, you're a healthcare professional, so you have a look at the patient, you take note of the endotracheal tube or ETT size. So there's a size, okay, on your endotracheal tube. For example, size 6, size 7, size 8. Okay, so in Western countries, for example, here in the UK, so we've got size 7 and size 8. For really big people, there's size 9. Okay, but most often we see size 7, size 8. And then these patients who have, let's say, smaller built, so seldom we see size 6, 6.5. But yeah, most often we have 7 and 8. Okay, and then position. Okay, position of the endotracheal tube. So I'd say this is very important to check. Okay, when you're doing your patient and safety check. Okay, position means the marking or where the tube is sat. Okay, for example, at the lips or at the lip level or at the teeth level. Okay, so the endotracheal tube has markings on it. Okay, numbers. You will see numbers 23, 20, 21, 22, 23, and so on. Okay, so, and it's secured by either an ET tie, okay, a tie, or we're now in 2025, okay, so we've now got some devices that help secure the endotracheal tube. So there's what we call anchor fast, okay, so it's something that we use to secure the ET tube. So we then take note of the marking. That's very important. It's to make sure that the tube has not moved elsewhere, okay, because if it moves significantly, it may affect the breathing of the patient. Okay, it may compromise the breathing of the patient as well as the oxygenation if it's not in the right place. Okay, that's why after the doctor, okay, puts the endotracheal tube, okay, into the trachea, of course, it's best practice to have it x-rayed to confirm the placement, to confirm that it's in the right place. Okay, so that's that. So an example, endotracheal tube, size 8, tied at 23 centimeters at lips or 23 centimeters at teeth. Okay, so when you write your documentation from your assessment, so it's best if you specify, okay, the endotracheal tube size and then the marking or the position. Okay, so that when something happens, like something untoward happens, okay, your patient's oxygen just becomes compromised, it drops, and then you can always recheck. Maybe the tube has moved or the tube has been moved, okay, unintentionally. So that's why on your assessment, you need to take note of that. Okay, let's proceed. So still under the airway, so we've encountered tracheostomy. So some of you may not have encountered tracheostomy. Okay, so what's tracheostomy? Okay, so for those who are unfamiliar with tracheostomy, or some others, some people say tracheostomy, so it's a procedure that involves creating an opening, a stoma, okay, ostomy pertains to a hole, okay, or a stoma, okay, and then trache, okay, pertains to the windpipe or the trachea. So it's a procedure that involves creating an opening or a hole in the trachea or windpipe to facilitate breathing. Okay, that's your tracheostomy. Okay, and there are two main types of tracheostomy. So in the clinical setting, you will see or you will have seen percutaneous, and then the other one is surgical. Okay, so what's the difference between the two? So percutaneous tracheostomy can be done at bedside. It is less invasive, it is quicker to perform. Whereas surgical tracheostomy, okay, needs doing in an operating room or in the UK, theater. And it involves or requires general anesthesia as well. Okay? So that's your tracheostomy. Those are the two types, okay? Some healthcare facilities, they have this laminate form that show healthcare professionals what type of tracheostomy the patients got. Okay, it's a laminate that has percutaneous tracheostomy, surgical tracheostomy. They just need to indicate which one. So everyone will know what kind of trachea the patient's got. Okay? Also, take note of the size. So there's sizing as well when it comes to your tracheostomy. Okay? So that's part of your assessment as well. So check, does the patient have tracheostomy? And these patients, by the way, why do we put tracheostomy? Well, I mean, why do the doctors put tracheostomy or consider putting a tracheostomy? So one reason is when it's difficult to wean someone from the breathing machine or from the ventilator. For example, 2 weeks have passed and the patient cannot be weaned off the ventilator. The patient still needs time to fully recover chest-wise. So that's when the team, the medical team, consider putting a tracheostomy. And it will take time. This will take some journey for the patient, rehabilitation-wise. Okay? So it's gonna be quite a journey for the patient, but this timeline is important for them, that we support them, okay? Because it's the road to recovery. Okay? So they need time. That's why the doctors put tracheostomy. Equally, we then help them with gradually being able to swallow. So we will involve the speech and language therapist for the swallow check and speaking as well, alongside with a physiotherapist, okay, to continue with the weaning plan. Okay? When do we put oxygen? When do we stop putting oxygen? When do we try those things? Okay? So those are things to consider. So that's what we call multidisciplinary approach. So there's the doctor's input, there are the nurses' input, you have the speech and language and the dietitian input, as well as your physiotherapy input. Okay? So um, in our healthcare setting, so that happens in patients with tracheostomy. But also, all patients have this multidisciplinary approach. But those are the things that we consider in patients with tracheostomy. Okay, next. Breathing. Okay, so we finished with letter A. So letter B. Letter B stands for breathing. Okay, so breathing, we check the patient's breathing rate. Is it fast? Is it slow? Okay, so fast breathing is termed as medically tachypnea. And then slow breathing, okay, is termed as bradypnea. Okay, so what's the normal range for the breathing rate or respiratory rate, clinically speaking? So the normal respiratory rate is 12 to 20 cycles per minute. So anything less than 12, that's called bradypnea. Okay, brady means slow. And then anything above 20 is called tachypnea. Okay, tachy or fast. Okay? So when those two happens, bradypnea or tachypnea, there will be an underlying cause. Okay, for example, bradypnea or slow breathing can be caused by medications like analgesia, anesthesia, or morphine, for example. And then tachypnea or fast breathing may be caused by maybe you've done a marathon. Okay, you're scared. Okay, you're in pain. You're angry. So emotions can cause fast breathing as well. Okay, you're doing exercise. Okay, so that's that for the rate. And then you check the depth as well. Is the breathing shallow? Is the breathing deep? Okay, look at the patient's or the person's chest. Okay, in terms of chest expansion. Okay, the chest, when you say chest, there's left side and there's right side. Okay, do they rise and fall equally or symmetrically or asymmetrically? Okay, so that's chest expansion. And then accessory muscle use. So there are some muscles, okay, that are not really being used in normal breathing, but in some people with some respiratory issues or problems, these muscles that are not usually used on normal breathing are used. Okay? And this indicates labored breathing. For example, due to chest infection or pneumonia, or maybe there's fluid buildup in the lungs or the pulmonary edema, clinically speaking. Okay, or it can be evident with people with severe COPD. What COPD? Chronic obstructive pulmonary disease. Okay, wherein air that cannot be breathed out becomes trapped in the lungs. Okay, so these are the things that we check or we see, okay, during the breathing assessment. Okay, let's proceed. So under breathing is the person on room air. Okay, when we say room air, okay, so there's what we call fraction of inspired oxygen, okay, or what we call FiO2. Okay, so what's FiO2 or fraction of inspired oxygen? So this is the percentage or concentration of oxygen that we inhale. And you and me both breathe around 21%, okay, of that. Okay, FiO2 of 21% in room air. Okay, so is the patient on oxygen? Okay, check the patient. Has the patient got oxygen device attached? Okay, is there any mode of oxygen delivery? If there's oxygen, what's the mode of oxygen delivery? And what's the oxygen saturation? Okay. In terms of oxygen delivery devices, so we've got the following. Okay, one is nasal cannula. Okay, we have the face mask or simple face mask. In other references, they call it Hudson mask. Okay, you have Venturi mask, and then you have non-rebreather, or again, in some references, reserva mask. Okay, so these devices give or deliver different amounts of oxygen in liters per minute. Okay, let's have a look. But before that, here's what they look like. Okay, oxygen cannula. It's a long tube. Okay, with these prongs. Okay, these prongs go into your patient's nostrils. Okay, and then this port here attaches to the oxygen supply. And then for the face mask, so this part here attaches to the tubing that attaches to the oxygen, and then this mask, okay, a mask, so it covers the patient's nose and mouth. Okay, so somehow there's a bit of seal, but there are still some holes there where the oxygen may escape. But as compared to this is more closed. Okay, a closed unit. Okay, there's a bit of seal there. And then when it comes to your Venturi mask, the Venturi mask, this involves color-coded valves, okay, that you attach to the mask and the tubing, okay. So each valve, okay, they're color-coded. So they've got corresponding number of liters per minute to deliver, okay, oxygen-wise, and administer a specific concentration of oxygen to the patient. Okay, and then lastly, you have the non-rebreather mask. Okay, so what's the difference between the face mask and the non-rebreather mask? So the non-rebreather mask has a reservoir bag. Okay, so we need to fill this in first, okay, with air, okay, with oxygen before putting on to the patient. So this has to be inflated first. This has to be inflated first. Okay, so those are the commonly used oxygen delivery devices. Okay, so this is the table, no? According to the British Thoracic Society, okay, these are the respective flow rates for each device. Okay, for example, your nasal cannula delivers 1 to 4 liters per minute. The simple face mask gives 5 to 10 liters per minute, or it will use 5 to 10 liters per minute. The Venturi mask uses 2 to 15 liters per minute, and then your non-rebreather mask or your non-reb mask will have the flow rate of 15 liters per minute. And this is the oxygen concentration they provide. Okay? So, that's that. Okay? So, 1 to 4, 5 to 10, 2 to 15, 15. So in other references, in other resources, you will see different flow rates, even different concentration. But as per the British Thoracic Society, this is the flow rate. Okay? Next. So in terms of the Venturi mask and the valve colors, so we have five commonly used valve colors in the healthcare setting. So there's blue, there's white, there's yellow, there's red, and there's green. And each color corresponds to a set flow rate. And each color also administers or gives this specific oxygen concentration. Okay? So the blue has the least flow rate, amount of flow rate, and the least inspired oxygen concentration. And then the green one uses the highest flow rate and gives the highest oxygen concentration. And that's your 60% oxygen concentration. Okay? So that's the order of the colors. And these plastic tubes, okay, let me just go back. So this plastic tube, it's written, okay, the flow and the concentration is written or indicated in each valve. So you won't get confused, okay, whenever you pick one up. So it will say, for example, the green one, it will say 60%, okay, 15 liters, for example, okay? So that's that for the Venturi. Or also additional input, no? In patients with chronic obstructive pulmonary disease or COPD, Venturi mask is one of the best oxygen delivery device to use. Why? Because they give exact flow rates. Okay? There's an exact flow rate. Okay, I want to use the red because I just need this one. I want to use the blue because this gives 2 to 4 only. Okay, remember that in patients with COPD, there's oxygen retention, carbon dioxide retention, so you don't want to give too much oxygen. So you just give minimal oxygen unless the saturation indicates the need for doing more. But normally, you would then just give less, okay? Because we aim at oxygen saturation of 88%, okay? For these patients or these people. Okay, breathing. So if this conventional oxygen delivery device or oxygen delivery methods don't work, we then introduce you to the nasal high flow oxygen, okay, or the high flow therapy, okay? So this is another mode or form or way on how to deliver oxygen, administer oxygen. So high flow, let's go to high flow now, okay? So in your nasal high flow, what's important there is the humidification through a high flow oxygen delivery. Okay? So humidification, okay? So this is humidified oxygen, humidified, moistened, or warmed. Okay? High flow oxygen through where? Through the nostrils. You can see here in the photo. Okay? So there's a nasal cannula, but this is much bigger compared to the normal or standard nasal cannula. So there's a wet circuit here, the heated breathing circuit, which is attached to the humidifier, which is this one. There's a tubing attached to sterile water here. Okay, so water flows there via gravity, and then it's gonna be humidified, and the oxygen is gonna be humidified, and then the oxygen will go there. Okay, the air with the oxygen goes there to the circuit and then to the patient. Okay, so the key word there is humidified oxygen. And if the standard or conventional oxygen delivery doesn't work, that's the high flow. That's when the high flow will step in. Okay, it's like a bridge between the normal oxygen delivery and the mechanical ventilation and the non-invasive ventilation. Sorry, so it prevents someone from becoming intubated. It prevents someone from becoming attached to a breathing machine. That's the job of the nasal high flow. Okay, through administration of the humidified oxygen. Okay, so normally we administer 60 liters. So nasal high flow can do 60 liters, 60% to 100%. But when, for example, in our clinical healthcare setting, when a patient first comes in, we then start that patient with about 60%. And then we go up or we go down, depending on the patient's requirements. Okay? Okay. So there's flow in liters per minute, okay, or liters, I mean, and then fraction of inspired oxygen and humidification temperature. Okay. So for example, these are what we call the settings. What's the setting of the high flow oxygen of the patient? So for example, it's 60 liters, 60% at 37 degrees Celsius or heated at 37 degrees Celsius. But most importantly, we take note of these two. Okay, how much flow, how much oxygen or FiO2. Okay, so flow here acts as the support to the patient for the breathing. For example, your patient's breathing too fast and then try and give a bit more of flow or support. Okay, if that will help. If the patient's breathing is relaxed and then this may come down, you can give less. Okay, if the patient's oxygen saturation or oxygen level is low, and then go up with the oxygen concentration. If you've already achieved the oxygen concentration, and then go less. So that's how you titrate it. Okay, depending on the clinical condition of the patient. Okay, it's always based on the patient. Okay, and then the humidification, ideally 37, but some patients, they cannot tolerate, they said it's too hot. So sometimes we slightly adjust it just to help with the comfort of the patient. Okay, so that's your nasal high flow oxygen. Okay, humidified oxygen. Humidified and warm. Okay, under breathing still. So let's go to the non-invasive ventilation. Okay. So key principles in the non-invasive ventilation. So you have the CPAP and the BiPAP. Okay. You have the CPAP and the BiPAP. So CPAP stands for continuous positive airway pressure, while your BiPAP stands for bi-level positive airway pressure. Okay? What's the key difference between the two? So your CPAP delivers a continuous single level of air pressure, while your bi-level positive airway pressure delivers two levels of air pressure. Okay, that's why it's called BiPAP, bi-level. Bi means two levels of pressures. Okay, so one for inspiration or one for inhalation, and then the other one for exhalation. Okay, or what you call the inspiratory positive airway pressure or IPAP, and expiratory positive airway pressure or EPAP. Okay, so that's that. Okay, so this is an example, okay, of your CPAP machine. So patients or people who, if you've heard of sleep apnea, so some people suffer, not really, some people have sleep apnea, and they need that in order to keep their airway open when they are fast asleep. Okay, so it's attached to a mask, and then they set the machine to a certain pressure. Okay, that will help them, okay, maintain their breathing air and oxygenation during sleep. Okay, so patients who own this really know how to use the device. So sometimes the nurses on the unit are unfamiliar with the machine. So the patients themselves, they really know because they've been using it for years and years already. So they really know how to use their own. Except for if they're really poorly, if they're really like critically unwell, critically ill, and then we use our own machine, okay? And then we use our machine to deliver the CPAP to the patient. Okay? So that's the key difference, okay? CPAP, continuous single level of air pressure. BiPAP, dual level, two levels of air pressure. Okay? So you will see two numbers on the machine for the BiPAP. Well, that's for the for the machine we've got, okay, in our setting. Okay, under breathing, let's go to the invasive. Okay, so these two, they are called non-invasive, but they are forms of ventilation. Okay, they help. Okay, with the ventilation already. So this one is the invasive. So when you say invasive, something goes into the patient. Okay, we're talking about what? The throat. Okay, the windpipe or the trachea. So we're talking about endotracheal intubation. Okay, that's why it's called invasive. Endo means inside. Yeah, whereas the non-invasive, this doesn't go inside. This is a mask. Okay, where in here, invasive, we put the endotracheal tube. Remember the tube that I showed you earlier? Okay, so that's your invasive ventilation. So we take note of, so on your breathing machine or the ventilator, okay, on your breathing machine or the ventilator, there's what we call mode, okay, mode of ventilation. So oftentimes you see spontaneous or duopac. So what's the key difference again with this? So spontaneous meaning patient has spontaneous breathing, okay? They trigger their own breath. Whereas in duopac, it's designed to support spontaneous breathing. Okay? So that's a couple of years ago we've been using duopac. Okay, and then there's another one which is the assisted ventilation. Okay, or the ASV. Okay, so let's go to the pressure support and this positive end expiratory pressure or PEEP. So what are these two? Okay, these terms, oh my dear. So pressure support, okay. So pressure support is the added pressure that gives a little push, okay, to what? To help achieve adequate lung volumes. Because some patients, yes, they trigger their own breath, but their breathing, the ventilation is still not quite there. So they still need a bit of help from the breathing machine. So that's the pressure support. So it's a bit of pressure that helps achieve this volume in the lungs. Okay? What's the positive end expiratory pressure or the PEEP? Positive end expiratory pressure. So positive, okay, going to the patient, end expiratory, end of the exhalation, and pressure. Okay. Take it this way. So this is the pressure applied by the mechanical ventilator or the breathing machine at the end, okay, of each breath. At the end of each breath to ensure that the alveoli won't what? Collapse. What's alveoli? Okay, anatomy. Alveoli. Alveoli are the air sacs in the lungs and that's the site of the gas exchange. What gas exchange? The oxygen and the carbon dioxide. Okay? So it gives a bit of a boost, okay? So this little air sacs won't collapse. Okay? This pressure keeps the alveoli or the air sacs open, okay? In order to facilitate more gas exchange. Because if they collapse, then there's less gas exchange. If they don't collapse, then there's more gas exchange. Alright? So that's the principle, okay? That's the difference, okay? Pressure support, added boost to improve the level of what? Volume of inside the lung. And then this one helps keep the alveoli open, okay? To allow more gas exchange, okay? And then fraction of inspired oxygen, I've already told you that earlier. And then the rate, so on the breathing machine, some modes, okay, like your duopac, okay, the anesthetist or the intensivist in some countries, for example, in the US, the respiratory therapist, okay, as discussed with the doctor maybe, they can manipulate the rate. But in some territories, here in the UK, the ICU nurses can manipulate the rate, okay, or change the rate, as discussed with the physician, of course. Okay? For example, the patient's arterial blood gas reveals high carbon dioxide, okay, or the PCO2. So we need to expel that excess carbon dioxide by how? By breathing more, breathing a bit faster, and that's by increasing the rate on the breathing machine. And the duo pop mode allows that. Okay? In SPONT, there's no rate manipulation because the patient triggers his own breath. Only in duo pop. Okay? Next. I hope that's clear. I hope that's clear. I've done my best to make this clear to you guys. Okay? Okay, under breathing. Okay, so patient's cough. Okay, is the patient able to cough? Yes. Okay, let's say the patient is awake. Yes, the patient is able to cough. Is it weak? Is it adequate cough? Is it a strong cough? Some patients, bless them, they have weak cough. So they need deep breathing and coughing exercises. They need help from physiotherapists as well. Okay? To help with cough and secretion clearance. Because if secretions aren't cleared, they stay in the chest and then they block the airway. They disrupt the gas exchange. Okay? Sometimes we call it mucus plug. The patient's oxygen levels drop because there's mucus plug, because the patient's unable to cough it up. Sometimes it's because of patients not moving a lot. Okay? The patient's just lying in bed. Or sometimes the patient's what? The patient's just got a weak cough. The secretions are too thick. So those are some causes why there's mucus plug. And they obstruct, okay, the air passages, okay, or the breathing passages. Okay, secretions. So I've just mentioned about secretions. So in terms of secretions, we take note, okay? We're talking about assessment. So we take note of the amount, okay, amount of secretions. Is it minimal? Is it moderate? Is it large? Consistency. Are the secretions loose? Are they thick? And then quality. What do the secretions look like? Mucoid. Okay? Mucoid means like mucus, mucoid. Mucopurulent. Sometimes I associate mucopurulent with something infectious, such as chest infection. And then when you suction the patient, you get um, colored secretions or sputum or phlegm, frothy, okay, and then blood tinged. Okay, has a bit of blood tinged. So those are the things to assess, okay, in terms of cough and secretions. Things to include in your assessment, I mean. Okay? Sometimes going back to cough, guys. Sometimes cough, there's no cough. For example, the patient is mechanically ventilated, intubated. The patient's not coughing. Because even if you suction the endotracheal tube, the patient's not coughing. So we get worried about that. The physios get worried about that. The doctors get worried about that. Why? Because it can be what? The patient may be too sedated, okay? Very deeply sedated, or maybe there's an ongoing neurological issue already. That's why the patient's not coughing. That's why presence of cough is being checked as well as part of your assessment, especially in intubated patients. Okay? Hope that's clear. So still under breathing, let's go to auscultation, guys. So breathing sounds. Okay? So there are more references regarding breathing sounds. There are videos you can watch. Okay, audios you can listen to in terms of breathing sounds. So for the purpose of this presentation, I'm going to do a description only. And then you can search for the audio. Okay? That's the limitation of this presentation. I don't have the audio of the breathing sounds. I can only give you a description. And these are some common breath sounds, okay, in the critical care setting. So number one is wheeze, okay? So wheeze, some of you may be familiar with wheeze. So it's described as high-pitched hissing sound. Okay, when do you hear wheezes? In patients with asthma, okay? So why is there a wheeze? Okay, because there's narrowing of the airway. For example, in bronchospasm, so your bronchi, spasm means what? Narrowing. It involves narrowing. Okay, that's why you get this sound. Okay, so a wheeze indicates narrowing of the airways. That's why you give medications that open the airways. Okay, dilate the airways. Okay, like your salbutamol nebulizers. Okay, that's to counter the narrowing of the airways. And then you have the stridor, which we've already talked about earlier. So it's a high pitched sound, okay? High pitched sound, okay? Which may indicate obstruction in your larynx or the box, or the trachea or the windpipe. Okay? Next, you have crackles, which can be coarse crackles and fine crackles. So coarse crackles are described as low-pitched, bubbling, gurgling sound, such as in fluid congestion or fluid overload. Okay, pneumonia as well. So fluid overload, what heart condition, okay, involves fluid overload? Okay, your congestive heart failure or heart failure. And then fine crackles, these are high-pitched popping sounds. Okay, you normally hear them where? In restrictive and obstructive lung diseases. Okay, so these are some of the common breath sounds. So the most common I'd say are the wheeze and the crackles in critical care, because there's asthma, there's COPD. Okay, patients in critical care. There's heart failure patients in critical care. Okay, and those with severe chest infection. Okay, the sickest patients come to critical care. Okay, so you hear these breath sounds. Okay, wow, A and B are done. Let's go to letter C, cardiovascular. Okay, so onto cardiovascular, so we assess what? We talk about what? Okay, so we cover blood pressure. What's the patient's blood pressure? Okay, heart rate and rhythm. Oh, isn't it observations or vital signs you're talking about? Yes, because they fall under the cardiovascular assessment. You have the blood pressure, you have the heart rate and the rhythm, you have temperature even. Okay, and then one more key takeaway for the key cardiovascular. One more thing to assess is what? Capillary refill time. Your capillary refill time, or CRT. Okay? You have familiarize yourselves with this when you're at uni. Okay, as nursing students, medical students, okay? But capillary refill time, it's not part of the main or core observations or vital signs. So, what's capillary refill time? Okay? So, it's the time, okay, length of time it takes for the blood to return. How do you check this one? So it can be done centrally, it can be done peripherally. So peripheral, you let's say you pinch the nail bed, okay, for 5 seconds. You count 1, 2, 3, 4, 5, and then you release, okay, and then take note of the amount of or the number of seconds it goes back, or it refills, okay, the nail with blood. Okay? So that's the capillary refill time or your CRT. Normally, it's less than 2 seconds. Normally, it's less than 2 seconds. Same on the patient's chest, okay, for the central capillary refill time. Okay? Say you put your thumb, you press on the patient's chest lightly. Okay, lightly, alright, lightly. Okay, for 5 seconds, count, and then release. And then you will notice, okay, the change in color, indicating blood flow return, or the refill, or the capillary refill, per se. Okay, 5 seconds. And the usual is less than 2. And why do we assess capillary refill time? Why do we include it in our assessment? It's because under cardiovascular, okay, cardiovascular assessment covers perfusion. Okay, perfusion. Perfusion of what? Okay, oxygen delivery, nutrient delivery, but mainly oxygen. Because the poorer the perfusion is, the less or effective oxygen delivery is. To where? To the vital organs, the heart, the brain, the kidneys. If there's less oxygen in these vital organs, less function, and they're more likely to fail. There's heart failure, there's kidney failure, okay? And there's even damage to the brain, which is irreversible if there's a prolonged lack of oxygen. Brain damage, okay? That's why capillary refill time is a nice assessment tool as well, okay? To check for the level of perfusion. It gives you an overview. Of course, there's other way to check for perfusion. You can check the urine output as well, okay? But this is one way to check, okay? For the perfusion. Okay, next, under cardiovascular. So we have blood pressure. Let's talk about blood pressure, one of the vital signs, one of the observations. So what do we call the normal blood pressure? We call it normotensive. Oops, everything showed up already. I was just asking for one. So what do we call the normal blood pressure? Normotensive. What about high blood pressure? Hypertensive. Okay, this is review for those who are unfamiliar or those who are new to these terminologies. Okay, so those who are really seasoned healthcare practitioners, so be patient. Okay, I'm trying to cover the other side of the audience. And then hypotensive means what? Low. Hypo, low blood pressure. So, what's the normal blood pressure of an adult? Okay? Because in infants, it will be different. Yeah? So, let's talk about adults here. Okay? So, that's 120 over 80 millimeter mercury. 120 over 80 millimeter mercury. So, anything above 140, okay? 140, that's considered hypertensive. Some people, they got high blood pressure, but they don't experience symptoms. What do you mean symptoms? You know, blurring of the vision, headache, dizziness, lightheadedness, headache. So those are signs and symptoms of hypertension or high blood pressure. So you need to check your blood pressure. Okay? And then anything less than 90, okay? Okay, systolic. What do you mean by systolic, by the way? So you know the blood pressure, 120 over 80. So 120 is called the systolic blood pressure. That's the number at the top of the blood pressure. And then the 80 is the diastolic. So let's go back. So if it's less than 90, your systolic, okay, that's low blood pressure or hypotension. Okay? And that's pretty scary, hypotension. Why? Why is it scary? Hypotension can mean what? Can indicate less fluid volume in the body. Okay? Can be blood volume. Less blood volume. Okay? And massively low blood volume or fluid volume may lead to what? It may lead to arrest. Okay? It can lead to the heart stopping to pump. Okay, that's why we check the blood pressure. We ensure that the blood pressure is within the normal range. Okay? And the average blood pressure in an adult is 120 over 80. But don't get me wrong. Some people, this is what's normal for them. For example, people with tiny build, okay? Like petite people. So, for example, 100 over 70 is normal for them. 90 over 70 is normal for them because they're tiny. They're not massive build people. Okay? So we should consider that as well. Is that normal for you? You can ask the person or the patient. Is this blood pressure usual for you? Okay? Because for petite individuals, that could be normal. But for some, it's not normal. Okay? So we can ask them if it's usual blood pressure for them. Okay? So that's your blood pressure. Oh, what are some symptoms of low blood pressure? Okay, so patient may experience dizziness, lightheadedness, what else? Cold clammy skin, sweating, okay? So those are the signs. Pale, okay? Being pale as well. Okay, sign of low blood pressure. Okay, let's go to the next part. So heart rate and rhythm. So in critical care, most often than not, your patients are gonna be attached to the cardiac monitor. So you can see the heart trace, the heart rate and rhythm, the heart trace or the ECG trace. Okay? So take note of this. What's this? Rhythm, heart rhythm. So you have the sinus heart rhythm, that's the normal. Okay? Sinus tachycardia. Okay. Oh, let's go there again. Terminology. So tachy means what? Tachy means fast. So fast heart rate. And then brady, on the other hand, means slow heart rate. Now, what's the average range, normal range for the heart rate? So the normal average range for the heart rate, sorry guys, I didn't put everything I'm talking about to the PowerPoint. You need to take down some notes if ever you're watching here to learn. So 60 to 100 beats per minute. Okay, 60 to 100 beats per minute is the normal heart rate. Okay, so that means anything less than 60 is called bradycardic. And anything higher than 100 is tachycardic. Okay? And then there's atrial fibrillation. Okay, fibrillation means quivering. Okay, quivering. And then which what? Can lead to clot formation. And we've talked about this during our what? What topic was that? Drug calculation, no? So fibrillation, atrial fibrillation may lead to clots. The clots can form in the legs, what you call deep vein thrombosis. And then when it detaches, the thrombus is the clot. It becomes an embolus because it's now traveling. When it travels to the lungs, okay, to the pulmonary artery and then the lungs, you call it pulmonary embolism. Okay? If it goes to where? If it goes to the blood vessel in the heart, coronary artery, that's your coronary artery disease. When it goes to the blood vessels in the brain, it impedes blood circulation, and then it will cause what? Cerebrovascular accident or stroke. That's why atrial fibrillation need to be managed. So oftentimes the doctor, okay, your doctor will prescribe medications for that, okay, to help with the heart rate and rhythm, to prevent quivering, thus preventing clot formation, untoward clot formation. And then therefore preventing those conditions from happening. Okay? So yeah, when you see atrial fibrillation and the patient's not known to have atrial fibrillation, what can we do? We can do an ECG to confirm and then escalate it to the doctor. Also check if there's any chest pain or palpitation from the patient. Okay? Some patients have low heart rate. For example, athletes or active individuals, okay? Most often they not have lower heart rate. And then for fast heart rate, it could be due to what? Pain, okay? Difficulty breathing, anxiety, fear, okay? Fear of what? Fear of the wife. Okay? So fast heartbeat, okay? So for this, we treat the cause. We treat the cause. Okay, deep breathing exercises, giving analgesia or pain relief. Okay, if the high heart rate is due to the low blood pressure, and then we treat the low blood pressure, so the heart rate will settle or come down. Okay, so that's your cardiovascular assessment in terms of the heart rate and the rhythm. So normally, the rhythm is what? Regular. Okay? If it's irregular, it could be this, atrial fibrillation. If the rhythm changes, maybe it's due to electrolyte imbalance. Maybe the potassium's not in range. Maybe the magnesium is quite low. Okay, so sometimes it's electrolyte imbalance causing these changes in your heart rhythm as well. So if you note some rhythm changes, which is quite unusual to your patient in critical care, might as well have a look at the electrolytes. Maybe the electrolytes are low as well. Okay? Next. So we've mentioned, sorry, we've mentioned about temperature. Okay? Temperature as part of the cardiovascular assessment. So let's have these terms. Oh my dear, we have these terms again. I can see hypo, normo, and hyper. So you will encounter this a lot in the clinical setting. Okay, what more in the critical care or emergency? Okay, so hypothermic, okay, or hypothermia, or pyrexia, or febrile means high temperature. Okay, to those who are new to these terms. And then normothermic or normothermia or apyrexial, afebrile means what? Normal temperature. Normo. Okay. Thermic refers to your temperature. Normo means normal. Hyper means high. And then hypo means low. Okay. So low temperature. So in hypothermia, high temperature, we give or we do what? We do things that will cool down the person. Okay? Ice bath, wet sponge bath, paracetamol, cold water, fluids. Okay? And then for low temperature, we offer what? Blanket, hot drinks. But in severely sick patients, critically ill patients, we make use of warming blankets, for example. Okay? And then normothermia as well. Normal temperature. So nothing to do with that. Okay, your patient is what? Completely fine. Okay. Okay, so that's your cardiovascular assessment. Let's go to D, which stands for disability. Okay, D or disability. Okay, so in disability, we have a look at the patient's general appearance, okay, level of consciousness, AVPU. What's AVPU? We'll see on the next slide. And then Glasgow Coma Scale. Glasgow Coma Scale, or it checks the level of consciousness as well, how alert the patient is. So let's dive into the next slide. So AVPU, what's AVPU? It's an acronym which stands for 4 words. Okay, this reflects a person's level of consciousness. Okay, A stands for alert, V for verbal or voice, P for pain, and U for unresponsive. Okay? So, alert. How do you say a person is alert? The person is watching television, drinking coffee, chatting with family, playing games. Okay? Eyes are open, talking to you. Okay? So, the patient or the person is alert. How about verbal or voice? Okay? So, the patient is unwell, and then you call the patient. Okay, John, can you open your eyes for me? And then John opened his eyes. He responded to you. He responded to your voice. So that person is responsive to voice or to verbal cue, verbal stimulus. Okay? And then the third one is pain. So now, John, can you open your eyes for me? But John doesn't open his eyes. So now you inflict a bit of pain. Okay? You apply painful stimuli to the patient or to the person. And then now, John responds. So that means he's responsive to pain. So you can apply pain to where? You can apply pain to the upper part of the eye. Okay? Okay? Not on the eye itself, okay? just the upper part of it, above the eyelid, okay, or the supraorbital. And then you have the trapezial, okay. You squeeze your shoulder. That's a trapezial pinch, okay. So those are examples of stimuli that may help your patient respond to you. And then unresponsive, you've done everything. You've done voice, you've applied pain, but still nothing. The person did not respond. So the patient is classified as unresponsive on the AVPU scale. Okay? Next. So we also assess pupil response here. Pupil assessment. Okay? If you remember Perla, okay? Pupils equally round and reactive to light and accommodation. So when you shine light, okay, how do you assess pupils? You shine light, you use a pen torch, okay? So when you shine light to one eye, the other eye should react as well. Okay? Equally round and reactive to light and accommodation. So now there are some conditions where you can find pupils like this. Okay? So I've got this one from M. Cage. Okay? So for example, unequal pupil. Okay, one is, what's this? Dilated or constricted? Dilated. Okay, bigger pupils, dilated. Smaller pupils, constricted. So one pupil is dilated than the other. So it can be due to this, nerve compression. It says here, cranial nerve number 3. Okay? Both are dilated. It could be because of midbrain injury. Okay, irregular pupils could be because of orbital trauma. Orbital pertains to the eyes. Okay, conjugate gaze deviation. Okay, could be due to frontal lobe lesion. And then small or pinpoint pupils, which is one of the common observation under pupil assessment. So it could be due to an injury on the pon or pontineria, or due to medications like opiates. Okay? Morphine, for example. Okay? Pinpoint pupils. Alright? So this is one of the common findings, okay, in critical care. Okay? Patients who took overdose of opiate, for example. Okay? So this is Glasgow Coma Scale. Okay? So it shows how alert, how awake a person is. Okay? It uses 3 criteria. Okay? Using eye response, a verbal response, and then motor response. Okay? And then they are scored according to the response to each criteria. Okay? For example, for eye response, the person's eyes open spontaneously, so you give 4. The patient did not open his eyes at all despite of verbal or pain stimuli, so you put 1. Verbal response, the patient is orientated to name, place, time, person. Okay, perfect. You ask the patient. You ask the patient, can you tell me where you are right now? Can you tell me what day it is? Can you tell me what time of the day what do you think the time of the day it is? And everything, all the questions have been answered correctly. So the patient is orientated, okay, to person, time, and place. So you give a score of 5. The patient says, I'm at home, but he's in the hospital. So he may be confused. So you give a score of 4. Okay, sometimes the patient just says words that don't jive with each other. Okay, incoherent words. Doesn't apply to context. So you give 3. Okay? How about patients only moaning, grumbling? You could only hear sounds. Okay? Actually, it's called incomprehensible sound, not inappropriate sound. Maybe it's my typographical. Sorry about that. But yeah, it's incomprehensible sound. So you give 2. And then no sound at all, no words at all, no verbal response at all, 1. Okay? Motor response. Okay? So obeying command. Can Can you wiggle your toes for me? Can you squeeze my fingers, John? Okay? Patient obeys commands. Give 6. Okay? You apply pain to a certain part of John's arm. Okay? And then he tries to push away your pain stimuli. For your hand, for example, give 5. Okay? That means, the patient doesn't obey command, but able to localize the pain by pushing your hand away. So, give 5. Okay? Flexion withdrawal. So, he withdrew from the painful stimuli. Give 4. Okay? And then you have this abnormal flexion and extension. Okay? Decorticate. Okay? The arms flex toward the patient. Decorticate. And then, extension, the arms, okay, move away, extends from the patient, decerebrate or decerebrate. Okay? Decorticate towards the patient, away from the patient, decerebrate. Alright? I hope that helps you remember it better. And then no movement at all, no response, no motor response, give 1. So the highest score for the GCS or the Glasgow-Coma scale is 15. And the lowest score is 3. Okay? That's when you associate, oh, the patient's in a coma because the GCS is 3. Okay. So can we intubate that patient? Yes. Because the patient's not, alert enough to support airway. Okay? So low GCS is a candidate for intubation. Okay? People with low GCS. For example, people who took medication overdose. Okay, opiates for example. All right, or some other medications that can lower someone's level of consciousness. They are candidates for intubation because they are unable to support their airway. All right? Okay, so that's GCS. So you can always search for this online. Okay, if you're unsure, if you don't memorize this one, and then you can always search for this one. Myself, because I don't use it a lot of times, I still haven't memorized it. But I've got some, pictographic memory of what it's like in my brain. But to calculate, I still take some time. Okay? But I know the criteria by heart. Alright? Next. Under disability, so you check if the patient has sedation ongoing, especially if the patient is intubated or ventilated. Okay? So sedation including propofol, this is your sedation. For example, a patient in surgery, so the anesthetist give them propofol, okay? And then pain relief / sedation as well. Okay? Alfentanil and remifentanil, with the latter being more, I can't say short acting, but you can wake patients up faster when you give remifentanil than the alfentanil. So I think the proper way to say it, alfentanil stays a bit longer in the body compared to the remifentanil. That's how I would say it. And then dexmedetomidine, or some brands called Dexdor. So it's some sort of anti-agitation, okay, to patients who we are trying to wake up. Because some patients, because of this sedation we're giving, okay, because of the sedation we're giving, they become agitated because of the sedation. Okay? Agitation related to sedation. And this is the bridge for that. In order for us to wake the patient up without them becoming too agitated. So this is some sort of calming them down. Okay? The dexmedetomidine. Okay, in some patients, okay, some patients are mechanically ventilated, but their lung compliance is very poor and they're not synchronizing with the ventilator or the breathing machine. So there's ventilator asynchrony, that's what you call it. Okay? So the patient does his own thing, the ventilator does his own thing. So there's ventilator asynchrony. So sometimes the doctors, I mean, intensivists or anesthetists consider giving paralyzing agents or muscle relaxant to some sort of take over a bit with the patient's breathing. Because there's asynchrony, it's difficult to ventilate. We call it difficult to ventilate the patient, the person. Difficult ventilation means difficult gas exchange, challenging gas exchange. Okay? Because the patient's lungs and the ventilator, they're not in synchrony. Okay? They're not driving together. So, example of paralyzing agents or muscle relaxants include the atracurium and cis-atracurium. Okay? So, it's important we check the patient's BIS. Okay? Excuse me, guys. I'll just drink. Okay? And then I will continue for a while. Okay, guys, thank you for waiting. Thank you for your patience. I was just a bit thirsty with the throat drying up. Okay. So again, so patients on these medications, no, so muscle relaxant, paralyzing agent, it's important to monitor what we call bispectral index or the BIS. Okay, so it helps health professionals, nurses, and the doctors to see if the patient is too sedated or not. If we're giving too much muscle relaxant and sedation or not. Okay, normally we aim for BIS score, okay, or bispectral index of between 40 to 60. Okay, the lower the BIS, the more sedated the patient is. The higher the BIS, for example, above 60, the less sedated the patient is. Alright, that's your BIS, BIS, bispectral index. Okay, so that's sedation and muscle relaxant. So under disability, you also have this RAS, okay? Because in patients who are intubated or ventilated, they are being given sedation. Okay? So we then assess for the Richmond Agitation Sedation Scale. What? RAS. Okay? What's the patient's RAS? I don't know. Okay, so this is RAS. So it ranges from +4 or +4 or just say +4 to -5. And these are the corresponding description. Okay? The higher the RAS, the more agitated the patient is. Okay? The lesser the RAS, the less agitated the patient is. The less responsive the patient is. Okay? Let's start from -5. So let's say you assess the patient is not rousable, the patient doesn't respond to voice or physical stimulation, then score -5. No matter what you did, the patient's unresponsive, RAS is -5. Okay? But if there's some movement or eye opening, okay, even the slightest movement or eye opening to your physical stimuli, okay, the patient's RAS is -4. Okay, next. If the patient has eye opening, okay, but no eye contact, okay, yes, the patient opens his eyes but doesn't look at you or anyone else in the room. So that's -3. Okay? If the patient wakes up to voice opens the eyes, but let's say there's eye contact but less than 10 seconds, that's minus 2. All right? And if there's eye contact, which is more prolonged, above 10 seconds, that's minus 1. And this is the RAS we want. 0. What does 0 mean? Alert and calm. Okay, alert and calm. But the patient looks a bit anxious. Plus 1. Patients moving quite frequently but non-purposeful and fighting the ventilator. Plus 2. Okay? The patient pulls lines and tubes. Oh my dear. The feeding tube has been pulled by the patient. Plus 3. And lastly, if the patient is combative, plus 4. So make sure even plus 1 or plus 2 escalate it to the doctor already. Okay? Or if the patient's on sedation and you're allowed to titrate it, you may up titrate it as long as it's safe to do so. Otherwise, it needs escalating. Okay? This plus 1 to plus 4. Alright? Okay. Moving on. Disability. Okay. So disability also covers blood sugar. Okay? So here we go again. Normal, hyper, hypo. Normoglycemia. Okay, glycemia pertains to the amount of sugar in the blood. Normoglycemia means normal blood sugar or normal sugar levels in the blood or normal blood sugar levels. Hyperglycemia is high blood sugar and hypoglycemia is low blood sugar. Now, what's the normal blood sugar? So textbooks say 4 to 7. Okay? But in some clinical facilities, okay, 10 or higher is considered hyperglycemia. And then if it's above 15 or 15 or higher, you then check the ketones. So again, that's protocol in some facilities. Okay? In some areas, a blood sugar of less than 4, you then give glucagon intramuscularly. Okay, and then recheck the blood sugar in 15 to 20 minutes. Okay? So why is blood sugar important, especially if the patient's diabetic or if the patient's unresponsive? Okay, so hypoglycemia is associated with brain damage. So there can be neurological deficit. Okay? Due to the low blood sugar. So that's why part of the neuroprotection, okay, is to maintain blood sugar within the normal range. Okay? So that's blood sugar. Okay? Especially if the patient's diabetic, so we need to monitor the blood sugar. If the blood sugar is up and down, fluctuating, blood sugar reading is everywhere, and then refer this person to the diabetes team. Okay? Diabetes specialist if your clinical area has one. Otherwise, escalate to the doctor. Especially if the blood sugar is high, the ketone is high, who knows? The patient might be developing what? Diabetic ketoacidosis. Okay? Alright. So next, okay, mobility. So disability, of course, we assess for the patient's mobility. Whether it's independent, okay, the patient is able to mobilize on his own, walking to the toilet, okay, the patient's independent. Supervised, so you're quite unsure about your patient's mobility, so I might as well watch him. He might fall. Okay, supervised. Okay, assisted, and then it can be handheld, okay, with close assistance to the patient. You hold the patient while mobilizing, okay, or assisting the patient to sit in the chair, assist the patient to use the Zimmer frame, okay, so those things, mobility. Some patients are being transferred with hoist. Okay? Hoist. Hoist. So it involves the use of sling to transfer the patient from point A to point B and vice versa. Alright? Next, exposure. Okay. We're getting there. We're on the second half now. But I think this is much faster now from exposure onwards because airway and breathing took more time because of the airway bits. Okay? Exposure. So, what do we assess for exposure? So, we check for contraptions or attachments to the patients, lines, tubes, cables, such as your endotracheal tube, as I've discussed earlier. You have your central line, okay? So in critical care, a central line is inserted by the physician in order for us to give medications centrally. Some medications can only be given through a central line, like potassium infusion, norepinephrine or noradrenaline infusion, okay? In some clinical settings. Okay, can you take blood using the central line? Yes, you can take blood using the central line. But there's a protocol for that. You have to discard some sample first before taking the actual sample, and then you flush the central line with saline. Push and stop method. Alright? Okay, who puts the central line in? The doctor puts the central line in. Aseptically. Okay, they gown up. They do it with a sterile field because it's quite deep. You can see the length of the line, yeah? You can see the length of the line. Alright? In endotracheal tube or intubation, it's quite critical because it's airway. Any compromise will compromise the patient. Okay? Any major error can kill the patient because it's airway. Yeah? Okay, next is VASCATH. Okay? What's a VASCATH? VASCATH stands for vascular catheter, and it's inserted by the doctor to a patient who needs filtration. Some sort of dialysis, basically. Okay? Hemofiltration, hemodialysis. That's what a VASCATH is for. It's got 2 lumens. Okay? A central line has 3. It can be 4. It can be 5. VASCATH has 2 lumens. Sometimes there's a third lumen for medications. Okay? Is VASCATH considered a central line? Yes. It's considered a central line. Okay? Next, we have oro or nasogastric tube for feeding. Okay? For feeding or feeding tube. Are nasogastric tubes always for feeding purposes? No. Okay, not all nasogastric tubes are for feeding. There's a gastric tube inserted to what? To drain gastric contents. For example, in bowel obstructions, where the patient's feeling sick, okay, not absorbing effectively, because bowels are not working as what they should. Okay, so not all gastric tubes are for feeding. Some are for drainage. Okay, some are for decompression. Okay, to decompress the tummy because it's so distended due to some reasons. Okay. So that's that. And then you have the arterial line. So in critical care, the doctor inserts an arterial line for us to monitor blood pressure real time. Okay, it's attached to the monitor and then we'll be able to see the blood pressure reading. It goes up, goes down, but it gives you the real exact reading at that point of time. So we don't have to use the blood pressure cuff because there's the arterial line. And you can take blood sample from the arterial line as well. Okay? And then cannula. Okay, cannula. So You know what it's for. You're very familiar with it. It's for medications. Okay, cannula. Okay, more on exposure. So take note if the patient has a chest tube or a chest drain, abdominal drain, likely following a surgery, or stomas. Okay, I didn't put a stoma picture, just the stoma bag. But yeah, normally after the procedure, and then urinary catheter, if they're for fluid monitoring, no, fluid intake and output monitoring, and if they've got dressings, okay, broken skin areas. All right. Next, skin integrity. So talking about dressings and skin integrity. So check for pressure areas, check the surgical site. Is the surgical site, does it look infected? Is it bleeding? Is it red? Does it have foul odor? Does it have pus that I need to escalate to the surgical team? All right. Is it glued or dressed? Are there staples? Okay. Surgical site and wound site. Cuts and bruises. Okay. Bruises maybe from previous cannulation attempts. Okay. Previous attempts to bleed the patient. Okay. Pressure areas. Okay. So remember your pressure areas. Okay. Heels, elbows, back of the head. Okay. What else? Sacrum. Okay. Those bony points, bony prominences at the back. Okay. Pressure areas. Next. Oh, letter F already, guys. F stands for fluids. So we assess the following in terms of fluids. Is the patient on IV fluids? Is the patient receiving IV fluids for hydration? Okay? So we take note of what rate it is. Okay? We need to check. Maybe it's changed. Okay? We need to check the rate. Okay? If the patient's on diuretics, is the patient being given diuretics to get rid of excess fluid? Let's say patient has fluid build up. Patient may be too congested with fluids and the patient needs to secrete those fluids through urination. Okay? Or excrete, I mean, through urination. Okay? So common diuretics in critical care. So you have the furosemide. Okay, we talked about this in one of the previous video, and one of the important considerations for this is to check the potassium level. Okay, because loop diuretics like furosemide wash away potassium as well. But you got a potassium sparing diuretic, and that's the spironolactone. But it's more on the tablet form for this drug or medication, while your furosemide is available in tablet and intravenous forms. Okay? Next, in fluids, urine output. So, we mentioned capillary refill time may indicate perfusion. So, urine output also can indicate perfusion. Less urine output, less perfusion. Primarily in the kidneys. Okay? So we have poly, okay? We don't say hyperuria here, okay? We have poly, oli, and anuria. Okay? We don't have normal urea. I'm not sure if there's normal urea, guys. I'm not sure if there's normal urea, but there's no hyperuria and hypouria. Is there? I haven't encountered such. You tell me if there's hyperuria and hypouria. But for sure, we've encountered lots of times poly and oliguria. Okay, polyuria means passing more than 3 liters of urine per day. Oliguria means passing less than half a mil per kilogram per hour. And anuria means passing no urine at all. No, almost to no urine at all. So what's the normal urine output then? So in some references, that's 30 mils per hour. But then again, it depends on the patient's body weight. Okay? So that's, okay, the normal urine output. If you cover this less than sign, this is the normal urine output. It should be zero point 0.5 or half a mil per kilogram per hour. For example, I weigh 80 kilos. So per hour, I should be passing roughly 40 mils. That's half of my body weight in simple terms. Okay? Right. So remember this, okay? So patient's polyuric, maybe the patient's diabetic, maybe the patient has sodium problems, that's why he's passing loads of wee. Or maybe he's just simply drinking loads of water or fluids per day. That's why he keeps going to the toilet. Maybe he's on furosemide, he's on diuretics. That's why he's passing loads of wee. Oliguria meaning the patient could be dehydrated or patient may have a kidney injury. That's why he's not passing urine that much. Or possibly urine infection. Maybe try to consider sending urine sample to confirm urine infection. How about anuria? So no urine output at all. So that's in severe cases of kidney injury. So sometimes we consider putting patients on filtration, hemofiltration, in order to take out some fluid, okay, and remove waste products from the patient. If the patient's unable to pass wee, again, wee contains waste products. And if the patient's unable to get rid of waste products through urine, it's gonna accumulate. It's gonna accumulate in the patient's system. Alright? And it's called what? Renal encephalopathy. Okay? Sometimes, if it's the liver that is problematic, okay, maybe because of too much alcohol intake before. So it's hepatic encephalopathy. So in here, it's renal encephalopathy. Okay, that's why it's important for the patient to get rid of the waste product to prevent that from happening. Otherwise, the patient will be confused because of the encephalopathy. Okay, continue. So under fluids, we talk about fluid balance. Okay, is there a fluid balance target for this patient? Okay, what's this patient's fluid balance after 24 hours? Okay, so we will find out if the patient's underfilled or overloaded. Okay, or just normal. All right. So there's what we call positive fluid balance, even or neutral fluid balance, or negative fluid balance. Okay, positive balance meaning the patient has more fluid in the body. Even or neutral is just average. You're in between, neutral. Okay, you're not overloaded. At the same time, you're not underfilled. Okay, and then negative, that means you're a bit dry or underfilled. All right, so it depends on the patient condition. If the patient, for example, has heart failure, would you like the patient to be overloaded? No, because there's already congestion happening in the heart. So you don't want the patient to receive loads of fluids. Just adequate, but not loads. That's how important fluid balance is. The patient's blood pressure is very low. Okay? So you'll consider giving fluid to the patient. Okay? Intravenously or orally. Okay? Right. So there you go. Okay? So we have these key terms, intravenous fluids. Okay? If we think the patient is dehydrated, okay? If the patient is underfilled or dry, so the patient may receive intravenous fluids. If the patient, for example, has sodium problems or has heart failure, maybe fluid restriction is appropriate. Okay? But some patients are quite naughty. They don't comply sometimes. And then diuretics. If the patient has received too much fluids, or if your team think the patient is overloaded with fluids, and then the doctors will consider diuretics. Okay? So that's fluids. Let's go to G. We're nearly done, guys. Well done. Okay? If you're watching this video. Okay, so gut or gastrointestinal. Okay, so under gastrointestinal, you talk about patient's diet. What diet has this patient got? Okay, is the patient on a normal diet, diabetic diet, vegetarian? Also consider allergies. Patient may be allergic to nuts, for example. Okay, patient may be sensitive to gluten. Okay, in terms of celiac disease. Yeah, so you consider these things, allergies especially, because you don't want your patient to have anaphylaxis because of peanut. Okay, so take note. You should liaise with your colleagues, like the dietitian, for example, or the kitchen, or the healthcare assistant, when they order food or meal, or when you order food or meal for your patient. Take note of the allergies. Maybe your patient has allergies to food. Next, appetite. Okay? So, how is a patient's appetite? Is it fair appetite, poor appetite? If it's fair appetite, then that's good. If the patient's able to finish the meals, okay, every time, that's good. But what if the patient doesn't eat much? Maybe consider referring that patient to the dietitian. Yeah? Or if it's allowed in your facility, health facility, maybe the family or the relatives can bring in some food, okay, if it's appropriate, okay, can bring in some food for the patient because the patient likes this food, except, okay, if there's dietary restriction. Let's say the patient has heart failure, and then um, try to advise not bringing in salty food because the patient already has heart failure or hypertension, and then the blood, for example, for in diabetic patients with already high blood sugars, and then they want cup of tea with sugar, and then you can try and maybe negotiate with patients, can I give your cup of tea with sweetener instead? Okay, because your blood sugar is already high, so there's a bit of health education going there. Okay, when you try to interact with the patient or with the other person. Okay, because you're trying to do the best for them so they can recover. Yeah. Next. Okay, so this is done in the United Kingdom. I'm not sure in other territories, but this is called MUST score, which stands for Malnutrition Universal Screening Tool. Okay, so you check the patient's body mass index, you check if the patient has lost weight in the last 3 to 6 months, and then you check if the patient is acutely ill or hasn't eaten for a few days. So it will calculate those of information are needed to calculate for the must score. And then if you try and search this one, it will show there the appropriate action that you have to take. Whether you have to refer that patient to the dietitian. But in critical care, because this is critical care, then it's part of the tick list, okay, to involve the dietitian. Because again, this is multidisciplinary approach. It's holistic care and treatment to the critically ill patient. So I think it's automatic we involve the dietitian and speech and language therapy. Say the patient's not able to swallow properly, so might as well refer the patient to speech and swallow therapy. Okay? Or speech and language therapy if you're not qualified to assess the safe swallow of the patient. Okay? Okay, so that's that. What I've just said, dietitian referral and SALT or speech and language referral. Okay, under gut, We also have the feeding. Okay, so let's say the patient is not on this because the patient's unable to swallow properly. So the patient is started on an NG or nasogastric tube feeding. Okay? For example, stroke patients who have difficulty swallowing, then the team will consider nasogastric tube feeding to optimize patient nutrition. Okay? Is the patient on that? If so, what kind of feed? How much is it running for? How long will it need to run for? And how long is the break? Okay, for this feed. Also consider the content of the feed. Example, if the patient's having diarrhea, maybe you want to liaise with the dietitian. Is the high fiber one still appropriate for this patient? Or if the patient's sodium is already high, maybe you can check with the dietitian and the physician. Okay? Maybe we consider the low sodium feeding, nasogastric tube feeding for this patient. So again, you're applying your role as a patient advocate there. Okay? You're telling them what they need to know, what the facts are regarding this patient, trying to present options and agree with something that will benefit the patient. Okay? Again, for patient's best interest, overall safety. Alright? Next, some patients may not be able to absorb any oral feeding, tube feeding, because the gut is not working properly. So for these patients, we have this total parenteral nutrition. Okay? So we involve here the nutrition team, the surgical team, and the critical care team. Okay? To agree, okay, on starting this. Because again, nutrition is one of the important aspect of patient care in critical care. Patients won't be able to recover quickly without proper or optimal nutrition. Therefore, we need to optimize patient nutrition. And this is one of the ways to do that if the patient's not absorbing properly. Okay? The feeding is unable to tolerate the feeding. Okay? They keep feeling sick, they keep vomiting. So how can we optimize nutrition like that? So that's the time this steps in. Okay? So also called TPN, total parenteral nutrition, needs a route, okay, for us to be able to administer it. It can be through a cannula. There's a peripheral protocol if your facility has a peripheral protocol, and normally or ideally you will need a PICC line, a peripherally inserted catheter line. Okay, it's like a central line but going to the periphery. Okay, like your arm, patient's arm. Sometimes they get discharged, okay, with the PICC line, with that line, just because of this nutrition. Okay, their gut isn't ready yet for oral intake. They need some time, okay, for their gut to recover. So they'll need this for a longer bit of time, period of time. Okay, and this can go through the PICC line. Okay, so a specialist individual then inserts the PICC line. Okay, and it's done in a sterile procedure as well. And giving this, you have to do it with a sterile technique as well. We need to ensure that we don't contaminate the giving set nor the PICC line when we administer total parenteral nutrition. Okay? Always remember that. Because again, the risk of having TPN is one. Number one, infection. Infection of the line. And the content itself, the bag itself, is a good breeding source for microorganisms. Okay? And the second risk is what? Hyperglycemia. Okay? This will raise your patient's blood sugar. So we need to monitor the patient's blood sugar. Okay? Next. So in terms of this feeding, whether NGT feeding or parenteral nutrition, so we take note of the rate, as what I've said earlier. In nasogastric tube feeding, we need to check if the patient's absorbing. Maybe yes, we're feeding, we keep feeding the patient, but the patient is not absorbing the feed. What do we do about it? Okay, then we discuss with a team, and maybe the patient may have something like prokinetics to help them absorb the feed. Okay? We have what we call prokinetics. Examples include metoclopramide. We know it's anti-sickness, okay, or anti-emetic, but it helps as prokinetic as well. It helps patients absorb the gastric feeding as well. Okay, aside from metoclopramide, there's the likes of erythromycin. Erythromycin is known as one of the antibiotics, but it's also got prokinetic properties as well. And then, when you give those medication, normally they like some sort of act as combo sometimes as well. So, you will be surprised. The patient will start absorbing the feeding. So, it's like magic. Okay, and then we've mentioned about sterile or sterility, okay, in terms of giving your TPN and inserting the PICC line. Okay, next. Okay, under gut. So you take note. Okay, has the patient got nausea? What's nausea? Is feeling of sickness, feeling of wanting to vomit. Okay, or has the patient vomited already? Yes or no? If yes, take note of how much roughly the amount, okay, of vomit, the color of the vomit, so you can record it, okay, on your fluid monitoring chart. And then bowels as well, bowel movement, we need to take note of that. And in view of bowels, we use the Bristol stool chart. What's the Bristol stool chart? So the Bristol stool chart gives a description of the stools itself. Okay, it's this one. All right, the characteristics of the stools, and you have types 1 to 7, where 1 is the hardest stool and 7 is the liquid stool. All right, if it's liquid and watery, then it's type 7. Okay, mushy consistency type 6. So I'd say protocol wise in some facilities, if it's loose like this, consider isolating the patient. Maybe the patient has infectious bug like norovirus, Clostridium difficile, or Clostridium difficile, whatever way you want to say it. But in short, it's called C. diff. Yeah? So the patient might need to be isolated into a side room so the infection won't spread. Because there was a time before, I think it's 2018, 2019, the whole ward, okay, one ward got closed because most patients or many patients from their ward got norovirus. So that involves vomiting and loose stools or diarrhea. So we need to consider, isolating the patient. And of course, because we're talking about stools, what's the universal way to prevent spread of infection and break the chain of infection? Yes, hand hygiene, hand washing. Okay? So that's that. Okay? Bristol stool chart. Okay? So your nursing and medical forms will have this one. Okay? If you're working in the UK, I'm not sure if this is being used in some other countries, but yeah, here in the UK, Bristol stool chart is being used. Okay, letter H is hematology. So all about bloods. Okay, so we then talk about or assess patient's blood count for the day. You send your purple top, your full blood count, red blood cells, white blood cells, platelets, hemoglobin. So those bits, just have a look at them. If the patient's platelet is low, maybe the patient will need a platelet transfusion, or maybe be careful when the patient's platelets are low, okay, with invasive procedures, because the patient might bleed out, okay. What if the patient's hemoglobin is low? Maybe you'll need transfusion as well, because the patient just looks too pale, too weak, okay. because the patient lost blood from surgery, for example. That's why the hemoglobin is low. Or maybe the patient's got GI bleed, GI bleeding, or gastrointestinal bleeding. So we need to monitor blood count. Okay? Electrolytes, as what we said earlier. Okay? Low potassium, low magnesium can cause what? Changes in your heart rhythm or patient's heart rhythm. Sometimes potassium can be too high. Again, too high potassium, too low potassium can put your patient at risk for what? Yes, cardiac arrest. So you need to ensure that they are being covered as well when you discuss about the patient in critical care. Okay, when the rounds happen, okay, the electrolytes need to be covered. So if they're low, we can replace them. If they're too high, and then we check if there are ways to bring them down to normal levels. Okay, sometimes we need to increase the frequency of checking these electrolytes if they're dangerously high or dangerously low. Okay, for example, high potassium. Okay, so the patient needs to have treatment for hyperkalemia. Hyperkalemia is high potassium. So sometimes that's glucose with insulin, salbutamol nebs, okay, calcium to protect the heart. Okay, so those things. And then we have clotting as well, okay, especially if the patient's prone to bleeding. Okay, you're taking patients to surgery, so they need, okay, to check the clotting. Maybe the clotting is really deranged, and then the patient has, some procedure to be done in theaters or operating room. So we need to consider these things. And then blood thinners as well. So good job for the doctors, no? So they ensure that blood thinners are reviewed and crossed off as necessary before doing a major procedure. Okay? Otherwise the patient will bleed to the max. And then transfusion, we've talked about it. Okay? Okay. So for transfusion, just ensure you do your group and save the cross matching. So paying attention to what? In terms of transfusion. So patient details is a must. Okay? You need to double check, triple check patient details. When you send the sample and when you're about to transfuse the blood or the blood product, always, always, always check. Okay? The patient details as well as the details on the bag. Alright? Because we don't want any transfusion reaction. And anaphylaxis is one of them. Alright? Next. Last, okay. So letter I in A to I stands for infection. Okay? So infection. So you talk about the following. Okay? C-reactive protein or CRP is one of the inflammatory markers or infection markers that we're watching if the patient's got some sort of infection. Okay, it is being monitored as well when the patient is receiving antibiotics. Okay, is it going up? Is it going down? Is it the same? Okay, so we need to see the trend per day. Is the patient on antibiotics? If so, what antibiotics is the patient on? Does this antibiotic need level monitoring like your gentamicin, vancomycin? Yeah? Has the patient got allergies to these antibiotics? Years ago, we used to do skin testing. I'm not sure if in some clinical areas, skin testing is still being done. But in the UK setting, we don't do skin testing. We just start the antibiotic treatment. Okay? And then next is your infection control status. Is the patient barriered? Is the patient infectious? Okay? What route of transmission? Airborne? Droplet? Okay? Contact? Okay? Or the mode of transmission, I'd say. All right? And then investigations. So have this or has one of these been sent, okay, for the patient? Maybe the patient spiking temperature. Maybe the patient has temperature of 38 or higher. Then we normally send blood culture, phlegm culture, okay, urine culture to check for chest or urine infection or any form of sepsis. Okay, stool sample if the patient's stools are loose. Okay. In 2020, 2021 or so, we used to do COVID swabs, but not anymore quite recently. I'm not sure with other territories. But we do send MRSAs, okay? MRSA swabs. And then immunology screens as well. If the doctors or if the team think that there's any immunology related checks that need to be done. Okay? Okay, and that's it, guys. Okay, so A to I stands for airway, breathing, cardiovascular, disability, exposure, F for fluids, G for gut or gastrointestinal, H for hematology, and I for infection. So, assessment helps in the overall care and treatment of the patient. With a good assessment, you'd be able to develop an effective plan, effective implementation of care and treatment, and reevaluate after implementing your care and treatment by reassessing, okay, the effectivity of what you've done, okay, of your current nursing care or medical treatment to the patient. Okay, so everything restarts with assessment. That's why reassessment. Okay, so I hope this presentation gives you or has given you loads of takeaway in terms of assessing your patient from A to I. Okay, I'll see you on the next video. Thank you very much for watching this video and have a good evening to all. Bye bye and have a good evening again. Thank you.